Welcome to Oncology Unscripted. My name is Matt Spraker, a radiation oncologist in Denver, Colorado.
My name is Katie Coleman. I am a kidney cancer patient and patient advocate in Austin, Texas.
And my name is Julie Johnson, and I am a sarcoma patient and patient advocate in St. Louis, Missouri.
We're teaming up to meet in the middle for a candid and educational podcast about cancer that is intended for patients, doctors, and their teams. This show and our opinions are meant for general informational purposes and are not medical advice. We encourage you to reach out to your doctors to discuss your individual case. Thanks for listening. Now let's get on with the show. Okay, so do you want to kick us off for this one?
Yeah, so diving into this episode here, we thought we would start off on an episode about terminology. So we're going to dive in and talk about who some of the people are that you see as you go through a diagnosis, you might see in some of your appointments, as well as just kind of terminology that you might encounter early in a diagnosis. I know that this was an area that I had a lot of confusion on and spent a lot of time trying to figure out. So who are the people that you end up interacting with in these appointments? And then I know it varies by center too. So maybe that's something that we can talk about as well.
In my clinic right now, I have a pretty small team. I have a front desk person that serves an administrative role, and that's important too. So like sometimes when you call and talk to someone, you might use the term scheduler or things like that. In some clinics, they may actually walk you back also to the room, that thing. You brought up blood pressure. So that's when you start to get into specific tasks that do require some training. You can't expect a random front desk person that has no medical training to take an accurate blood pressure. Even though these days machines kind of do it, you feasibly can, but you need some training. And so those are either usually medical assistants or nurses. And I don't know if you saw that. It can be hard to differentiate them, but it's kind of like different levels of ability to do things or skill sets to do things. So medical assistants tend to be more limited to collecting basic information and putting it in a chart. I've been in appointments like with my wife, for example, where a medical assistant might come in and like record the medications that she's taking, that kind of thing, or taking a blood pressure or taking some initial things like a weight. Usually nurses can do that stuff too, but they do more than just that, if that makes sense. I don't know if that starts to help a little bit.
Yeah, I think so. A question on like the medical assistant versus a nurse, for example. I'm trying to think back on my scenarios. And I remember part of my confusion when I was very first diagnosed is like, I was repeating my symptoms, what brought me in and what led to my presentation to like 3 different people. And I was like, why am I saying this 9 times? And so does a medical assistant like take some of those symptoms and like put some of those things in the chart? Are they like one of the people who are sitting there kind of going through the list of symptoms and entering that? And then like, I imagine a nurse may review that with you before.
They can be actually. Yeah. And that's actually a problem you point up. We were actually talking about university systems where they might have trainees. And one of the skills you need to train people to do is to take a history. And so you get the story from the person. And I always feel kind of bad because if you come in and you make them repeat that story, like it's not uncommon for people to get frustrated, like when they've told the story 3 times in the last hour to different people. It's kind of like a waste of the patient's time. And so I think that's a challenge as well. And so to answer your question, I think a good way to think about it is that there's overlap always between what these people can and will do, because in medicine, we've done kind of a poor job of putting very clear boundaries around what people are allowed to do. And that actually leads to we have this, I don't want to deviate too much, but that leads to a controversy that we have among practitioners in medicine is that the scope of what people can do can slide a little bit. And so if you're a physician and you work a lot with nurse practitioners who can do a lot of things that physicians can do, there's concern that they're starting to do too much with less training, if that makes sense. We can talk a little bit about that more. But anyway, there might be a medical assistant or a nurse that does the rooming and collecting that information. They can both definitely do that to answer your question. So it's hard to tell just from your story who that would have been, but it certainly would have been at least a medical assistant, not just a standard like worker that doesn't have medical training, if that makes sense.
Yeah. Sorry, go ahead, Julie. I think you were about to say something.
Well, I was going to ask a question, but I might be getting ahead of myself. So if I am, we can just table it to when it's the right time to talk about this. But one of the things that I've always wondered is when I go into an appointment and I share this information with a nurse or whoever, at what point is the physician actually getting that information prior to coming in to see me?
Yeah. Yeah. And so it could be, um, it depends, right? Because so this is actually hard to structure. So some of the information that is given and received and documented is in there because it's required to be documented for a doctor to be paid for the visit, if that makes sense. And it may have a lot of relevance to your visit or your case, or very little relevance to your visit or your case. And so generally what will happen is the medical assistants and the nurses will collect the information as standard, as kind of like a workflow. So in my clinic, the nurse will bring you back to the room, and my nurse tends to spend about a half an hour with patients before I'll see them. And it's collecting a lot of information, including vital signs, like blood pressure, things like that, but also medications, history, how they're doing, things like that. And then she'll actually come to my office and say, the patient's ready for you. And we'll talk for basically, 5 minutes or so. And we'll go through lots of things that I think are relevant that I need to know before I walk in the room. Because a lot of times in oncology, it's not like you're walking in and they're like, what brings you in today? Like your doctor kind of knows why you're coming, because they've heard a little bit about you already. And so it's usually filling in gaps or confirming things. Believe it or not, you'll give your story to medical staff or doctors, and it might not be documented entirely accurately. There might be small details that were miscommunicated or misinterpreted on their part. And so we'll clear those things up with patients to make sure we're all on the same page. And then that way, when I walk in, like I can assume that they can assume I've heard the story already, and then I might ask them only the relevant or very focused parts of it that are important for what I need to know. And so that we'll get most of that. Oftentimes I'll glance at a medication list, and if the nurse took the information about your meds and you're on a medication that's not relevant at all to what we're doing, I'll glance at it and I won't think of it again, and we won't really talk about it, if that makes sense. I think.
I was always curious how much of that transferred over, right? Like, so you're talking to the nurse for 20 minutes and then step out, the doctor comes in X amount of time later. How much of that information got transferred over I'm glad you asked that question, Julie, because that's something that I've always wondered.
Yeah. And the other thing real quick, just to add, is that in the university setting, there could be a trainee that serves that role. So, and they may be inserted into the workflow as an additional thing. So you may spend the 30 minutes with the nurse, and then you may get another 20 to 30 minutes with the resident physician, which we'll talk about the term in a second. And then they would come and actually talk about the case with the attending or the doctor that's kind of overseeing your case. And that part is not only communicating the information, but it's also evaluating the trainee, because one of the skills they do is have to present it to you efficiently. That might be a time that you ask them questions about what they would do in the case, that kind of a thing. And so there's some time spent there. And I would guess that for you guys have both been to both. I mean, I'm guessing you probably feel like maybe the appointments are a bit slower in the university, just because there's all those extra steps that are built in to a lot of clinics. At least from my perspective, it feels a lot more efficient in my new job where I'm in more of a community center. Yeah.
So maybe we can use that segue to discuss kind of what the trainees are. Like, I know when you mentioned trainees, and before I ever knew anything about medical system, I thought of trainees, med students. I thought these people were not doctors yet, and they're just still in school. So can we talk about what the different levels of trainees are that you may run into one? I'll just give an example for a scenario that I had that I didn't know the difference between these people, and it was very confusing for me as a patient. So for example, I know when I was going to get my biopsy, I talked to who was the fellow who I didn't know was not the main attending doctor, and gave me all the information, gave me the warnings and risks and everything. And we talked through everything, what the procedure was going to be like. And so I thought just, okay, he's the doctor. And then I went down for the laid down for my biopsy. And then when the attending walked in the room, like, and I had no idea that like that was the main doctor on my case kind of thing. So can you break down what the different levels of trainees are?
Yeah, and I'll just say this is America specific because it's different in different countries. But so here, basically, you have to graduate college first. So you have a bachelor's, and then you would enter into medical school, and those are medical students. And so like those people it's 4 years. It changes a lot, but most of the time, if you see a medical student in your clinic visit, they tend to be a little later. So they've sort of been through all the lectures of medical science and all that stuff, and now they're like kind of practicing in the clinic. And so that you may interact with them, and they tend to do very basic things. So they will, take histories, record medications, do things, and they'll learn, but they kind of do mainly like interviewing, if that's a good way to put it. Once you graduate medical school, you go to residency. So if you hear the term resident, that tends to be people who are graduated. So they're medical doctors, they have an MD, and they have a medical license, but it's a training license, meaning that they have to be supervised by an independent physician in some setting. They're not all directly supervised with every patient encounter, but they have to be supervised overall for their work. They have to work under an independent physician. In that residency, there's a separate term that we use, intern. I don't know if have you heard that term at all when you hear people talk about it? Yeah. So interns are specifically first year residents, and they tend to do, they have specific roles. And so like for my field, you actually do an internship where that's just medicine. So I did lots of other things that's not oncology, like you do cardiology and all different kinds of stuff. And then you graduate from the internship, and then you do your specialized residency for radiation oncology. And those are referred to as residents. Then the fellowship is a little bit different, where you graduated residency. And so you actually could go work independently, but instead what you do is you enter into another training program that's like specialized training. And so just to contrast that a little different. So like in my field in radiation oncology, you do an internship for 1 year and then 4 years of radiation oncology residency. And then basically everybody goes off into independent practice. There's some fellowships, but most people don't do them. And that there's some controversy around them, but that's a whole separate thing. Medical oncology, I think we said on one of the other shows, like that's who most people call their oncologists. They do a full medicine residency first. So they could graduate and go be a primary care doctor or be a hospitalist, which is like kind of like a doctor that does general medicine in a hospital. But instead they go into a fellowship, which can be a few years. I think usually it's 3, where they will do specialized medical oncology training on top of their general medicine training. And so like I'll tell my own patients that their medical oncologist is probably a better medical doctor than me, like internal or like internist is the term people used to use, because I'm so far away from my internal medicine training. I haven't done that in, at this point, like 7 or 8 years. And whereas they completed a full medical internal medicine residency and then went on to the specialized training. So if you see a fellow, they're essentially an independent practicing doctor who's entered into a program to get specialized training in a niche in a specific field like oncology. They're still technically a trainee, but the state, everyone in the country would consider them to be an independent physician because they have a full license and they can work independently. And they may even do that like on the side, separate from their training program.
Very interesting.
A lot of times medical oncology, like almost all of them do fellowships. That's how they become like a hematologist or a medical oncologist. And then surgeons do as well. So like a lot of pathways where you might do a general surgery where you like do 3 years of training where you're like just learning how to be a surgeon. And then you might become, for example, a breast surgery fellowship. And then your whole job after that is like treating breast cancer, if that makes sense. So that's where fellows come in. And they teach us, you're supposed to identify yourself. So I think it's funny that you brought it up in that way, because at least when I was a med student, my medical school was like every year they'd be like, you have to tell, people who you are. And so that way everyone like knows who everyone is in the room. And that's kind of a big deal at a lot of training places. Yeah.
I think they probably said who they were, but I had no idea what that was. Like, probably like I'm a fellow, and I'm like, that's an interesting way to refer to yourself.
Yeah. So I agree. I feel like I feel like people have always introduced themselves. It's just a matter of, do I understand what that means in the context of the other people in the room?
I think what's really important to understand is there's no like regulator about what beyond being a medical student. Once you graduate, you have an MD, and then states decide what you need to practice medicine independently. And so like in Colorado, like you have to show them that you graduated a residency, and then they'll give you a license. But beyond that, they don't actually care. And you don't need a fellowship to do cancer surgery. And that's actually like a controversial thing. Like a lot of people argue that the fellowship trained surgeons are better, like objectively better. So those people, like centers should have fellowship trained surgeons, but it's not like a state requirement. And you're allowed to be a breast cancer surgeon if you've just done a general surgery residency without a fellowship. And so that's where it gets a little messy. And there's not a lot of, we don't do a great job of like defining those, like the required training to do certain things.
I think even just at a high level, like I wish that just even the basics of like, here's the people you're going to see in your appointment. That's what I really loved about the NCCN guidelines when I mentioned that, is like it described who a lot of those people are. Because I'm not going to lie, half that information I learned like after my diagnosis by watching Scrubs and like watching them move up through the different levels there. And so that shouldn't be coming from a TV show. That should be.
No, and I don't know if you've like if you see it on Twitter, doctors pointing out how bad some of the TV shows are, like on their medical.
Oh, yeah.
Like they post pictures. I like the ones that anesthesiologists post where they have like they have like endotracheal tubes, which is what they put down your throat during a surgery. They'll have them like in people's noses and stuff, and like kind of all kinds of crazy stuff. And it, like my favorite was, did you guys watch House? That was like, I don't know.
Yeah.
No.
Yes.
But in that show, the doctors like would do everything. Like they would scan the patient themselves. They would then go take them over to the operating room and like operate on them, and then like give them radiation. And like that's not, I mean, you all know that's not how medicine really works. There's people that do all those individual things. And so none of it, I think you make a great point that so many people learn about medicine from TV, and it's often very inaccurate, which is, I guess, problematic. Yeah.
I have a quick question. I encountered most of these residents actually when I saw you as my radiation oncologist. I don't remember, when I think about my medical oncology experience, I don't remember a lot of other people other than a nurse or a physician assistant or the oncologist. But when I did radiation, I remember there was like a rotating group of residents that would come in and out. And I'm curious, like, how involved are the residents in treatment planning?
Oh, that's a great question. Yeah. Well, so just to quickly answer your first, or to elaborate on your first comment, in medical oncology, remember, like it's fellows, and you may or may not have seen fellows. But they tend to have.
I don't remember anybody like that.
Yeah, well, part of it, so it does vary from place to place, but some places, the fellows will do more of the inpatient care, or a lot of inpatient care. They also do a lot of research. And so that you won't ever see a researcher fellow because they're like in the lab. Right. And so that's one of the issues. And that's a particular, like that might be a specific thing about where you go. And there's other places that might do it a little differently. Residency in radiation oncology is an apprenticeship model. And so the way that everyone trains is they rotate around with different attending physicians or independent doctors, and they spend 2 or 3 months with them, and they'll kind of like work with them as if that's what they're doing. And so one of the things that is what I always struggled with was trying to like adjust what they do based on their experience level. Like in their first day, there's a ton of stuff that they don't know, and it's really hard for them to like kind of do treatment planning, for example. But like when they're close to their last day, you really want them to be doing like everything, because they're, a week later, they're going to be out there independently treating people, and you want to make sure that they can like do that effectively. And so it's hard to do that. And like, some people are so bad at that like you, like in some programs, you will never rotate with somebody that is only for like the older residents that are further along, because they don't temper what you're supposed to know for, so I think that's kind of how, but it is something that we struggle with for sure. You had a question on here actually about the term PGY or PGY1, that kind of thing.
I see that all over Twitter.
Yeah, it stands for post-grad year. And so that's a really easy way, because the terms residents and fellows and everything, an intern gets confusing. That's always true where, like, if you have graduated medical school and you go into training after the first year is PGY1, it's post-grad year 1, post-grad year 2, that kind of thing. And it goes all the way up to, like, 8 or 10, depending on what kind of field you're doing in medicine. Yeah, and then Julie, you mentioned physician's assistant. I don't think we even talked about that yet. Those are what the term I like to use is a mid-level, or a physician extender is a good term for it. Basically, it's someone who can do more than a nurse. They have more training, I think, than a nurse. They have kind of post college training, but not as much as a physician, and they're intended to be supervised by physicians. But it's a very controversial area, especially right now, because they are less expensive to hospitals than physicians are. And so there's a lot of places that they're looking for physicians' assistants or nurse practitioners to do things that a physician would otherwise do. And the concern is that they don't go to medical school, so they don't have the same training. It's substantially less training overall. And so I think in places where you need a lot of skill, there's concerns. And a good example of that would be I know in California, there's been a big political battle over what physicians' assistants and nurse practitioners can do. You can imagine if they have a practice on their own as a primary care doctor for somebody. They may miss things because they just don't have as much training. And so the concern is the quality of primary care will go down if you have a practice that's entirely made up of nurse practitioners with no supervision of a physician.
What is the difference between I know one of the things that I've had a question about is some of my appointments with some providers have a nurse practitioner that I end up seeing before the physician, and other ones have a PA or a physician's assistant. What's the difference between those two? Is there a different place for them? Or are they, I guess kind of what's the difference there between
the two, you mean?
Yeah.
Yeah. So that I'm going to get in trouble because I don't know the exact difference, and there probably is one, but in my opinion, in oncology, they're kind of used interchangeably, and they tend to be most used in follow-up clinics. And so my guess is you are more likely to see a medical oncologist in your consult appointment where you're getting started with them. Whereas if you finish treatment and then you're going every 3 months for a scan, you might see a nurse practitioner or physician's assistant, because that's how I did it, where it allowed me, I was supervising mine, but she'd work independently throughout the day. And so instead of me only being able to see 10 or 12 patients, together we could see 40. And 25 of those maybe didn't need me. And if they did, then she would grab me. And so that truly extended the ability of what I could do. And so I think it is very beneficial in oncology. Those people have a really important role, in my opinion.
Yeah. So a question on that. If you have somebody in that situation where they finish treatment and they're coming back every 3 months for scans, I guess it's realistic to assume that as long as they stay, no evidence of disease or in remission, which we can talk on those topics, they won't ever need to see you again. That person would kind of become their go-to and their point person for all types of questions, concerns, etc.
That's how I ran my clinic, particularly because I thought my nurse practitioner was excellent, and she sort of trained with me to the specific problems that come up in the couple of disease sites that I saw. And so that's how it was with me, where if they never had anything come up, they would just see the nurse practitioner every time. They developed a great relationship with her and people really liked it. If something did come up, then that's where I would kind of get back involved. And we would meet each morning and talk about everyone she was going to see. So I kind of knew about them. I'd hear about them in the background. Sometimes I'll admit that I get sentimental and I want to pop in and say hi to people because I miss them. And then very, very rarely, I mean, really, we're talking like one or two people out of 200 would feel strongly that they wanted a physician. And I'd even tell them I am worse at this than my nurse practitioner who does this all day. But that's what they wanted. And so we would still see them like that,
Okay.
So it was that's sort of how I would run my clinic. But just like the other thing, there's no, often it's sort of up to the doctor. There's no directive. You can kind of structure it how you want, and you can have them do other things. But that was how I was most comfortable and I felt was the best use of both of our time.
I think it's funny that you asked that, Julie, because I actually once I started getting into more of a surveillance phase, I started seeing, I think she's a physician assistant. Oh man, I feel terrible. The fact that I don't know 100% sure. But I started seeing her more often, and I loved seeing her. But then it was also one of those, sometimes I'd listen in the hall to hear which footsteps were coming towards the door. And I was like, am I going to get good news or bad news? Depending on who's going to come in.
That's right. I've always found that to be so interesting because I think that's the way they do it at my center as well, which is, well, I'm going to take that back and say, because I've switched oncologists recently, but the way that it used to be is if you were just in surveillance, you would see the physician assistant or the nurse practitioner, whoever it was. But most recently, it's almost been alternating. Like sometimes I will see an oncologist and then the next time I'll see the physician assistant and then back to the oncologist. But yeah, that used to be a joke kind of between my husband and I is like, I wonder who's going to open the door because whoever opens the door, then you kind of know the news that you're going to get based on the scan, right? Because if the oncologist walks through, you're like, crap, something happened. But if it's the physician assistant, then you're like, okay, cool, another 3 months. Here we go.
That's exactly so what happened to me last appointment. My oncologist popped in and I was like, uh-oh.
Yeah.
But, I love seeing both of them. And so it's nice when he popped in, but it was definitely one of those, I was like, uh-oh, this must mean bad news.
Yeah.
Now I'm wondering if I just popped in to say hi if I spook somebody because that's I don't have a nurse practitioner now, and so it's just always me. But that's a great point that I bet is true for a lot of clinics.
I still think it's good that you pop in though, because I'll say as a patient, I like it when my oncologist still pops in to say hi.
Yeah.
So I think it's also interesting. This is kind of an aside. I don't know, Katie, if you've ever experienced anything like this, but when the transition comes between the nurse, when the nurse leaves before the oncologist comes in, there's a nurse that I have experienced where she always, before she leaves, she always says, okay, good luck, and then closes the door. And it's always oh, that is there's just something about it where I'm like, can we not say good luck? Can we use something else? I don't know. It's just this awkward, I'm going to leave now. And the next person that comes to the door is going to deliver the news that you're here for. And it's this really awkward transition, but it always ends with good luck. And I'm like, oh.
I've had that a couple times. And especially because there's for me, sometimes there's a 30-minute window where you're waiting with that good luck, right?
Yes.
And so I've had that at sometimes, but I oftentimes now will have sometimes the nurse that comes in before is don't worry, I think you're okay. And they'll give me a preemptive, don't worry too much.
No, I just get your doctor will be in a minute. Good luck. And I'm like, oh gosh, no, can we say something else?
I could imagine that very anxiety provoking. Well, it seems like we're out of time today, right? So I think this is good. I like this. We should keep periodically talking about some of the terms and stuff because I think we don't do a great job of communicating that as physicians. And so,
yeah, definitely. Cool. Well, it's nice chatting with you all again. Until next time, I guess.
All right. See you later.
Yeah.